All right, so if you're working triage, especially in a place like ours, level 1 trauma, stroke, STEMI center.
Oh, yeah. The busy one.
Exactly.
Yeah.
Pushing, what, 120 patients a day sometimes? You know just how high the stakes are.
Mm-hmm. There really isn't a more intense spot in the whole hospital.
Right. You're the gatekeeper.
Yeah.
And every single call you make, like in those first 90 seconds, it sets the path for that patient.
And for the whole department's flow, honestly.
Totally. We all use ESI, the Emergency Severity Index, every shift.
Mm-hmm.
And it's easy to just, treat it like a number, check the box.
Yeah, just get it done.
But we got to move past
Yeah.
that, right? To really nail this job, ESI needs to be more than a task.
Oh.
It's the clinical mindset. It's how we talk acuity.
It really is the language. And mastering it is crucial, especially with that pressure. Because if you misuse it, if you under-triage a 2 or over-triage a 4,
The flow just dies.
it grinds to a halt. So the core mission, if you boil it down, is really 2 things. First, find the dying patients. That's acuity.
Find the ones who need us now.
Exactly. Then, only after you've cleared those immediate threats, then you sort the rest by predicting the resources they'll likely need.
Okay.
You know that firefighter analogy they talk about? It's pretty spot on.
Remind me.
Well, you show up to a fire, first job, find people trapped inside, right? Pure focus on life.
Right. Not worried about hoses yet.
Not at all. That immediate rescue instinct, that's your ESI 1s and 2s. Once everyone's safe, then you figure out how much water you need, how to fight the fire itself.
Got it. Acuity first, then resources.
Mhm.
Okay, let's dig into that. Part 1, the acuity questions. Finding those ESI 1s and 2s, separating the truly sick.
The ones who can't wait.
So ESI level 1, this is, actively dying is the term. It's a massive call to action.
Absolutely. Immediate. Life-saving intervention needed, like within the next 5 minutes.
No question. If you don't act, they're coding. Simple as that.
And yeah, sometimes it's obvious, right? CPR in progress, penetrating trauma, no BP.
Can't miss those.
But the real skill, I think, is catching the less obvious ESI ones, like the anaphylaxis patient. Oh, with the stridor.
Exactly. You hear that audible stridor. That airway is closing. They need immediate intervention. Epi, maybe even a cricothyrotomy. That's ESI 1.
Or the overdose patient who just looks sleepy. But their SpO2 is like 60%.
Profoundly hypoxic. Needs bagging, needs intubation now. ESI 1.
And the big GI bleed. Pale, barely conscious, BP 70 over nothing.
Massive transfusion. Right now, ESI 1. The key here is they have 0 reserve left.
0 compensation ability.
None. Think about that septic cancer patient on chemo. Their immune system is shot. No reserve. Or just baseline. Anyone with a GCS of 3.
GCS3 is automatic.
Automatic ESI 1. Needs airway protection, period. Non-negotiable.
Okay, so that's level 1, immediate life threats. Now, ESI level 2, this is where it's trickier, right? This patient can't wait.
This is definitely where your clinical judgment really has to shine. That gray zone.
Yeah, these are the patients who might look okay, but your gut, your experience is screaming that they're secretly circling the drain.
Exactly. They're the ones who will become an ESI 1 if they sit in the waiting room. So how do we pin them down? What makes someone a level 2?
Well, ESI gives us 3 main ways to catch them, and the first one is all about your pattern recognition. It's the high-risk story.
Ah, yes. Crucial for us, being a stroke and STEMI center, we have to pick up on those patterns instantly.
For sure. That 55-year-old clutching his chest, classic pressure.
ACS until proven otherwise. ESI 2.
Or the 28-year-old sudden thunderclap headache.
Subarachnoid hemorrhage on your mind. ESI 2. Straight back. No waiting.
Absolutely. Time is brain, time is muscle. Same for the 72-year-old with new facial droops, sudden weakness.
Stroke code. ESI 2.
Tearing chest pain radiating to the back.
Aortic dissection. Got to think about it. ESI 2.
And we can't forget the vulnerable ones. That lethargic, febrile newborn.
Neonatal sepsis. Immediate ESI 2. No question. It's about the risk profile, not just how they look right this second.
Spot on. Okay, second criteria for ESI 2.
Acute change in mental status. This one feels pretty clear-cut.
Yeah, it usually is. New confusion, new lethargy, disorientation.
Automatic ESI 2. The brain's not happy. Could be hypoxia, sepsis, stroke, whatever.
Big red flag. Immediate assessment needed.
And the third one?
Severe pain or distress. Now, we need to be careful here.
Right, not just someone complaining loudly about their chronic back pain for years.
Exactly. This is pain causing a physiologic response. You see it.
What are we looking for?
Writhing, maybe? Obvious distress. But also the vital signs that go with it. Profound tachycardia, hypertension, sweating.
Agaphoresis. Yeah.
Reacting to that mangled limb or the leg that's clearly ischemic and screaming for blood flow. That level of physiologic reaction, that distress, that's an ESI-2.
Okay, high-risk story, new confusion, or severe pain distress. But what if none of those really fit? The story seems okay, maybe. Mild cough, chronic back pain flares up.
But then you check the vitals.
The ESI2 safety net. This is key.
It really is. It's like the algorithm's built-in lie detector.
I like that.
Seriously, the patient might say, oh, I feel fine, but their heart rate is 140.
And that tells you something is wrong. They're compensating hard.
They're working way too hard. So even with a seemingly benign complaint, if those vitals hit the danger zone defined by ESI version 5.
Automatic upgrade to ESI2, regardless of the story.
Yeah.
Because they're about to crash.
Exactly. You have to catch them before they do.
So knowing those vital sign thresholds is critical. We don't need to memorize the whole table right now, but what's the pattern?
Well, for adults and older kids, say over 8 years old, the triggers are generally a heart rate over 100, respiratory rate over 20, or an O2 sat less than 92%.
Okay, HR100, RR20, SpO2, 92.
Right. But the crucial thing is how much tighter those margins get as the patient gets younger.
Because kids compensate differently and then crash faster.
Precisely. So for younger children, maybe 3 to 8 years old, that heart rate limit drops. It's over 140 now. And the respiratory rate needs to be under 30.
HR140, RR30 for the 3 to 8s. Still SpO2, 92.
Still less than 92 for SATs, yep.
And then the little ones. Infants, toddlers.
It gets even tighter. For toddlers and infants, say 3 months up to 3 years, the heart rate trigger is over 160 or respiratory rate over 40.
Wow. HR160, RR40? That's fast.
It is. And for the brand new babies under 3 months, heart rate over 180 or respiratory rate over 50.
HR180, RR50. Or SpO2, 92 for all of them.
Right. If any one of those vital signs hits that ceiling for their age group, they get an ESI2 slot. No discussion.
Because they have basically zero physiologic reserves.
Exactly. The system forces you to recognize that vulnerability.
Okay, so we've scanned for ESI1s. We've used the story, mental status, distress, and vital signs to catch the ESI2s. We've cleared the immediate threats.
We've cleared the burning building, so to speak.
Right. Now we switch gears completely. It's not about how sick they are right now, but
Predicting the future. What are they going to need? This part 2, the resource questions.
calculating the gallons of water.
You got it. And in our kind of high volume ED, getting this resource prediction right is absolutely essential for flow.
Keeps the whole place from backing up.
Yeah.
So what counts as a resource? We need to be clear on this.
Yeah, this trips people up sometimes. Think about it in terms of the intensity of the workup needed. What requires significant staff time, equipment, or intervention beyond just the initial doc or nurse exam?
Okay, so diagnostics. What falls under that?
Things like labs, blood work, urine analysis going to the lab, any imaging beyond maybe a point-of-care ultrasound glance. So x-rays, CT scans, formal ultrasounds.
And ECGs count.
Absolutely. ECG counts as a resource.
Okay. And then the interventions bucket.
This includes things like getting a specialty consult involved, any IV, IM, or nebulized medications.
Beds, okay.
And here's the big one people forget, IV fluids.
Ah, right. Even just one bag.
Even just a single bolus, say 500 cc or a liter of saline, that counts as one resource.
Why? Because it signifies something more serious is going on.
Exactly. It requires monitoring, IV access, reassessment. It's an active intervention. Also, complex procedures count. Think sedation, putting in a central line, doing sutures.
Sutures count as a resource.
Yep. Complex laceration repair is listed as one.
Good to know. Okay, so what does not count? This is just as important.
Right. The provider exam itself doesn't count. Simple point-of-care tests like a finger stick glucose or a urine dipstick done at triage.
Don't count.
No. Putting in a saline lock but not giving fluids or meds through it doesn't count. PO medications, simple wound care like cleaning and a dressing, giving crutches or a splint, a tetanus shot.
Things often done near discharge anyway.
Exactly. ESI is focused on predicting the intensity of the initial ED workup, not the entire stay or discharge process.
Okay, that distinction is critical. So patient is stable, no ESI 1 or 2 criteria met. Now we count resources if they need. How many for an ESI 3?
2 or more. ESI level 3 is the full workup, basically. These are a huge chunk of our patients.
So your brain at triage has to quickly run through a likely pathway, like abdominal pain with a fever.
Okay, you're thinking labs, probably blood and urine, that's 1. They'll likely get IV fluids, maybe IV pain meds or antibiotics, that's 2. And they might need a CT scan, that's 3.
Boom. 3 resources, ESI 3. Or someone who had syncope.
ECG 1, labs 2, maybe a head CT, depending on the story, could be 3. Definitely an ESI 3.
So 2 or more resources needed means ESI 3. But this is where prediction can fail, right?
Oh, absolutely. This is a common pitfall. You get someone, say, flank pain, dysuria, looks like a simple UTI, maybe an ESI 4, needing just a urine analysis, one resort.
But then you get their vitals or the provider sees them.
And they've got a fever of 103, heart rate's 120. Suddenly, it's not a simple UTI, it's pyelonephritis.
And the workup explodes.
Right. Now it's labs 1, IV fluids, and IV antibiotics 2, probably a CT scan to look for an abscess 3. That simple UTI just became a solid ESI 3, needing multiple resources and likely admission.
So getting that resource count right, or at least anticipating the potential need, is vital for not clogging up the ESI 4 spots with hidden 3s.
Exactly. Okay, so moving down. ESI level 4. This is one and done.
Simple, needs only one single resource.
Perfect example. Rolled ankle, looks bad, swollen, can't walk on it, needs an X-ray.
X-ray is one resource, ESI 4.
Or that clean cut needing stitches.
Suturing is a complex procedure, counts as one resource, ESI 4.
You got it. Straightforward.
And finally, ESI level 5, the easiest.
In terms of resources, yes. Exam only. These folks need 0 resources for their workup.
Like a simple rash, prescription refill, minor sunburn.
Suture removal, maybe? They need a provider's medical decision-making, maybe some simple advice or care, but nothing that counts as an ESI resource. 0 resources equals ESI 5.
Okay, that covers the mechanics of 1 through 5. Acuity, then resources. But that brings us to maybe part 3, the art beyond the algorithm.
Yes. Because nailing ESI isn't just about following the flowchart, is it?
Not if you want to be exceptional at triage, especially here. It's all the stuff the algorithm doesn't teach you. That, 6-foot assessment.
Oh, yeah, that comes from years of doing it, seeing thousands of patients.
That's synthesizing everything in a split second. How they walk to the triage chair.
Their skin color, their work of breathing, the really subtle stuff.
And that skill we all hone. Getting the crucial info out of someone who's rambling or panicked in, 90 seconds flat.
Huh. Yes, essential skill. And knowing how to read between the lines. Recognizing that the really quiet, stoic patient...
Might be way sicker than the person screaming loudly.
Absolutely. Or the baby is the classic. The baby who didn't make a peep when you took their vitals.
Oh, huge red flag for me. That's always bothered me more than the screaming baby. Why is that quietness so ominous?
Because making noise, crying, fighting, that takes energy. A baby, or even an adult who is just still quiet, maybe looking lethargic, they might be in compensated shock.
Conserving energy.
Exactly. They're conserving every last bit of energy, and that silence can be a sign of profound illness. They're close to decompensating. You spot that incongruity.
Like spotting the diaphoretic guy clutching his chest, your instinct screams, MI.
And you don't wait for the full registration or the ESI number. You know that EKG needs to happen now.
You override the standard flow because clinical agency demands it.
That's the art. And another big one, challenging those screening scores.
Oh, definitely. Like the suicide risk screening, patient checks all the no boxes, gets a score of 0.
But their affect is flat, the story feels off, they won't make eye contact. And you just get that feeling, that gut sense.
That's not just a hunch, though, is it?
No, it's critical thinking at the highest level. When you flag that 0 score and say, this person needs closer observation, you're seeing the deep disconnect between the checklist and the actual human presentation.
You're overriding the tool because your clinical assessment sees something more dangerous.
It's the same reason we bump someone to an ESI 2 based on vitals alone, even with a benign story. You're seeing the hidden decompensation. You are that critical human firewall.
So ultimately, the job at triage, especially in this crazy busy environment, often short-staffed, it's balancing the mechanics of ESI, the numbers, the resources, with that constant critical thinking.
Assessing how quickly someone might go downhill.
Yeah. And mastering that balance isn't just about getting the ESI level right. It's what lets the whole department talk the same language about acuity. It's what keeps those 120 patients a day moving safely.
Absolutely. Flow and safety depend on accurate, thoughtful triage. So, maybe a final thought for everyone listening. Think back over your last few shifts.
Okay.
The challenge usually isn't spotting the obvious ESI 2, right? It's finding the hidden 2 that you initially pegged as a 3, or maybe even the 3 you thought was a 4.
The ones that surprise you with how many resources they chew up.
Exactly. Think about a recent ESI 3 or 4 that ended up needing way more work than you predicted, tied up a room for hours. Looking back, was there a subtle clue you missed at triage?
Like their gait, their tone of voice, that quietness we talked about.
Could be anything. What tiny detail in retrospect might have hinted at the bigger picture and maybe bumped them up the acuity scale earlier? Connecting that resource prediction skill to the impact on overall department workflow, that's next level thinking.
That's how you really elevate your practice from just applying the algorithm to truly mastering triage.
Mhm.
Because you are the front line. You're setting the pace.
You're the gatekeeper.
The gatekeeper to the most critical real estate in the hospital. The efficiency, the safety. It really does start with your 90 seconds, your assessment, your mastery of ESI. Keep doing that vital work.
Couldn't agree more.